difficult conversations in a clinical encounter. During my time at FHC, I was able to work side by side with all the medical providers, and we implemented several different patient-centered kind of care things with self-management support and improving patient care and patient satisfaction. And one of the clinical tools that I found particularly useful is motivational interviewing. And as a result, I spent a lot of time learning and practicing MI, and eventually became a trainer and a member of the motivational interviewing network of trainers. So I'm not going to pretend that I can train any of you in motivational interviewing in 30 minutes. I often conduct trainings that are at an introductory level for 2 to 3 days. So anywhere from 14 to 21 hours of intro training. And then we do another level up with another 7 to 14 hours, and then a third level, and in between practicing and coaching. So that's not my purpose today. My purpose is to just provide a brief overview of some evidence-based communication strategies in clinical settings, to introduce a tool in particular for engaging in helpful conversations in your clinical practices. And that tool is called the EASE approach, where it basically just stands for elicit the main concerns, acknowledge the main concern, share your commitment, and educate and endorse what the research shows. And then I'll end with a few resources for you to explore. I like to start with a cartoon. This is a favorite of mine. This is a doc and a patient of his. Best way to achieve good health is to take care of yourself. Your lifestyle is destroying you. You should change your eating habits and stop smoking and drinking. Start an exercise program, get plenty of rest, learn how to handle stress. Oh, and get your COVID vaccine too. You're right, doc. Thanks. Man, I gotta find another doctor. And this is the least desirable situation for us and for providers in a clinical setting, is to argue for the change while the patient pushes back and argues against it. And simply by reducing what's called discord, this sort of interaction that doesn't feel good for anyone, increases the odds of a good clinical outcome. And what's known as the writing reflex, when we use the writing reflex in our clinical settings and our clinical practices with our patients, it actually leads to discord, and it can lead to that patient shutting down or even becoming outwardly defensive. And so what is that writing reflex? What does that sound like? What does it look like? We sometimes also might refer to it as the fix-it mode. Now, I like to preface this with saying that we come by this very honestly. You all were trained in a clinical practice. You were trained to help people by assess, diagnose, and treat. And in doing that, many times what we're doing is we're trying to fix it, we're trying to control it, and of course, we're trying to diagnose it. And this is coming from a belief that people actually don't know. So we'll give them information, because if they just knew, they would do. It may come from, we believe that they just don't understand, so we want to give them our insight. It could come from, we believe they just don't care, so if we scare them enough, it'll make them more concerned. Or we believe that they just don't know how, so let's give them the skills, tell them how to do it. And what our patients really need, especially in these situations where it's calling on them to change a behavior or to do something different, our patients really need to be listened to be understood, and to actually be the source of their own solutions. When we do work with people and we find ourselves using this writing reflex, what we're going to see in our patients oftentimes, and you may notice this in some of your patients some of the times, or you may have even felt it inside yourself when someone else is trying to tell you what to do and using the right and reflex on you. People tend to feel invalidated. They will resist. I think of it as kind of the big proverbial hand, or they will withdraw. They will just disengage and perhaps not return, or see someone else. So what we're really trying to understand is, how can we change our approach to one of more empathy and listening, especially in situations where we're asking a person to make some changes, some difficult changes in their life, or we're asking them to engage in something that maybe they just have said, I don't want to do that. So what we know is that we rarely take responsibility to make changes when others are trying to tell us that we must or what we should do. And in fact, we often argue for and do the exact opposite. And, we ask ourselves, well, why is that true? It's true because it's a psychological response from a person to push back and to try to maintain their own sense of autonomy and self-determination in their life. And so in 1966, a theory was born, and that is the psychological reactance theory, which really comes to play when we're trying to work with our patients in a way that is telling them what they could or should do. And what we know about the theory is that there's an actual increase in the rate and attractiveness of a problem behavior if a person perceives that his or her personal freedom, is being infringed upon or challenged. And I wonder if, when you think about the psychological reactance theory, I wonder, have you ever, done the opposite of what someone told you to do, even though what they suggested was really quite reasonable? Has that ever happened? I know it has for me. Because I'm like, oh, no, you don't get to tell me what to do. People would rather demonstrate their autonomy than comply. And sometimes healthcare professionals, we trigger that reactance because of the approach that we've taken. So if you find yourself using language like, you need to, you've got to, you must, it's really quite likely that you're going to trigger reactance in your patient. And when you think about this, even if something is illegal, for example, you can't go out and binge and then go drive. You can't do that. Your kids are in the car. You can't do that. Well, in fact, they can do that. We, of course, wouldn't want them to do that. It's a really bad idea. But at the end of the day, they could leave and go do exactly what we just said they shouldn't or couldn't do. And in fact, with the psychological reactance theory, if it increases that rate and attractiveness of the problem behavior, we're actually pushing them towards that problem behavior, which we don't want to do. So there's got to be a different way. And motivational interviewing is difficult. Everyone can learn this, I believe. It just takes time and practice and patience, with yourself, and getting some good coaching, I think, is really helpful too. But motivational interviewing is this strategy that has been used in many different settings. So just to give you a little background about what it is, it's a patient-centered guiding communication style for enhancing a person's own motivation, their intrinsic motivation for a health behavior change. And it works by exploring that person's ambivalence and helping them to resolve their ambivalence for the behavior change. The other thing to add on to that is there are many studies that have been conducted that illustrate the effectiveness of using MI with patients with behavior, lifestyle, even addiction, really entrenched, hard, difficult addiction issues, and very, very appropriate when ambivalence is present. So if a person is showing some sort of, well, I'm not quite sure, that's ambivalence. That's when MI can be very helpful. It's used in a wide variety of areas within the clinical setting. As I mentioned, substance abuse, exercise, diet, oral health, medication adherence. And there's evidence that MI is also helping with addressing vaccines, and especially when hesitancy is present. I want to say something about motivational interviewing in relationship to vaccine hesitancy. If we have a patient who's coming in and they are resolved to get the vaccine, then of course, motivational interviewing actually is not going to be helpful. We wouldn't ask that person, well, what would be the downside of getting the vaccine? We wouldn't want to bring them backwards. So when a person is ready to act, they're prepared and they're gonna do something, then we drop motivational interviewing. It wouldn't be the best tool for us to use. It's good when ambivalence is present. So let's take a look at, there's 3 different constructs that I want to talk about with motivational interviewing that I think are particularly important in this work of vaccine hesitancy. And the first one is the spirit of motivational interviewing. I think of motivational interviewing spirit as the heart set for patient-centered communication. And it's this belief in the ability and inherent resources and strengths that each person possess. And we're just there to help guide them towards their health behavior change. And so with the spirit of motivational interviewing, it has 4 different components that are really important. It's partnership, it's that collaborative conversation. It's not one way of giving information from provider to patient. It's collaborative, and it's an exchange. The patient is an expert in their life and with their family, and the provider is an expert resource and guide to better health. And when I think about this, I think about division of responsibility, and I think about how burnt out our healthcare providers and workers get, because we're taking on things that aren't our responsibility. Whose responsibility is it to make a behavior change, to take a medication, to agree to get a vaccine, right? And if we lift that and shift that responsibility to the patient where it belongs, and we do that in a way guided by the spirit of motivational interviewing, everybody can win. And actually, you can go home and hopefully feel a little bit less stressed and maybe more rejuvenated in your work. So evocation is another construct, and that's just evoking from the patient their own motivation and their own resources for health enhancing actions. And we want to invoke this inherent ability to move in a positive direction for health. Acceptance is really important. Acceptance means showing absolute worth, honoring a person's absolute worth and unconditional positive regard for our patients. It's about autonomy support. At the end of the day, you spend 15 minutes with a patient, they leave your office and they spend all the other minutes of their living hours away from you. So it's autonomy support, accurate empathy, and affirmation. So it's very much strengths-based. And then compassion. We get into healthcare because we do care. We care about our patients' well-being. So actively promoting patient welfare, giving priority to their needs, their perceived needs, and really valuing in a genuine way the well-being of our patients, which I think we're all in this because of that. A second construct is one of ORS, open questions, affirmations, reflective listening, and summarizations. These are skills that are not new to any of you. You're all using these skills every day. It's using these skills in a very intentional way to create a relational foundation and then to guide your patients towards a healthful change or a healthful behavior. And then lastly, the third construct that I think is really important from motivational interviewing is this construct of ambivalence. And the thing about ambivalence is that we all have ambivalence. If you have something that you want to do, but you haven't done it yet, you need to do, but you haven't done it yet, you have reason to do, but you haven't done it yet, you have ambivalence, right? So first of all, it's not pathological. It's just really being of two minds, having mixed feelings about something. And this state of mind in which this person has this coexisting but conflicting feelings about something, this is the space where we can help understand. We want to understand what that ambivalence is in our patients, and then helping them resolve that for themselves. So it sounds like I want to, but I don't want to. And it's a fundamental and normal part of the change process. So there's this different way with ambivalence. It's really about trusting in the patient's own wisdom for themselves. Our role is to help them explore that. As I said, our role is to be curious. And when we walk away from the encounter, rather than getting into a wrestling match where we feel like, you know, if they don't do something that we told them to do, then we're angry and it ruins our day. We're mad. It saps our energy. But in this situation, we stay away from that righting reflex. We recognize our responsibility in this interaction and what our patient is responsible for. And we, by engaging in that sort of evocation and really curiosity and seeking to understand, we can actually walk away with a clear understanding of the sources of their ambivalence. If not, maybe we can also help them move towards resolving that ambivalence. So with ambivalence, now to put it on top of vaccine hesitancy, what has this got to do with your work? So basically with vaccine hesitancy, we've got kind of three buckets of people. This is very much simplifying this, but we have, you know, some patients that are like, yeah, I could accept that, but, you know, I'm still I'm unsure about X, Y, and Z, okay? We could have some people that would accept, but they might delay and refuse some as well. So they're really the fence sitters. And then we have people who are going to refuse, but they're still unsure. You know, they're like, yeah, I'm not getting that. But, you know, I really don't want to get COVID, but I'm really not going to get it. Okay. So they're refusing, but there's still some uncertainty in them. And I call all of these buckets, this, what we call hesitancy with vaccines, I call this ambivalence. It's just basically another word for ambivalence. And what does that look like? You know, what does that sound like? And so when we're working with patients, these are some of the common things we might hear. And Paul covered some of the other ones. You know, for example, we might hear our patients say, I'm not too sure that it's safe to be vaccinated. So there's safety concerns. What's underneath that, right? Can we identify how that person is feeling? And then might we just take a moment and respond with some empathy? So empathy is a really important factor. I think you probably all know this in healthcare. In fact, I have providers who have said, and I get this, there's no time to use MI in my short, abbreviated visits. I've got 7 to 15 minutes with a patient. I don't have time. MI, first of all, is a brief encounter. It's meant to be delivered in 1 to 3 sessions with a person, but it can be done in very brief encounters. But moreover, if we just tap into how might that person be feeling And could I express empathy for them? That has been shown when we accurately express empathy, has been shown to cut 3 minutes off of a visit. And it's because if you can imagine, if we're missing it, what do our patients do when we're not getting it, when we're missing it? They repeat themselves. And it's just a huge dog chasing their tail kind of scenario. So expressing accurate empathy, trying to get it, validating a person's feelings is so important. So if we hear these kind of statements, we're trying to tap into, what's underneath that? So maybe it's fear, maybe it's worry, maybe they're just in a state of uncertainty. Maybe they're anxious. Maybe they have some other concern for their health. Maybe they're scared. Again, worried or concerned for their health. Maybe there's some distrust and some fear. So very important piece in our interactions. If I would say, if nothing else, if we can start tapping into what's underneath what our patients are saying to us. Maybe it's anger, maybe it's frustration, naming it. There's another theory that comes into play when we're working with our patients, and this theory is the self-perception theory, which was developed around 1967 by them. This is our objective, right? We're trying to evoke, we're trying to draw out the reasons why, the desires, the need to do something for one's health. And what we know about from the self-perception theory is that the more a person argues on behalf of a position, the more they become committed to it. So it works the other way. The more a person argues on not getting vaccinated, the less likely they're going to do it. The more they start to consider the other side of that, and if they were to decide to get vaccinated, what might be good about that, the more likely they're going to start to shift towards a different commitment. Because we believe what we hear ourselves say. And it becomes even stronger when we say it publicly. So there's some really good linguistic research that shows that the more a person verbalizes their own reasons and ideas for change, the more likely they are to change. And what we found is that when we're utilizing and really trying to embody that spirit, that way of being with our patients, that partnership, evocation, acceptance, and compassion, that our patients actually have these types of responses. They feel affirmed, they feel accepted, and they feel like you're approachable. They're going to be more engaged. So I always ask a little tongue-in-cheek, which patients would you rather work with, right? Ones who are defensive, oppositional, arguing, disengaged, passive, powerless, unable to change, and dislike you, or ones who are open, cooperative, listening, engaged, active, empowered, and hopeful, and they like you. So last but not least, with motivational interviewing, we have the writing reflex, that we have a rule about this and about it outside of just MI, just a way of being with our patients, to resist that writing reflex, to seek to understand a person's motivation for change, to listen to our patients, and to empower them. I'm going to skip this slide for now because we don't have a lot of time. And in terms of tools for what to take into the clinic for the lunch and learns, and I think it was Tara that talked about this, and it was a beautiful sort of setup and lead in. We all have our ways of agenda setting with our patients. So with patient activation and the literature around that, if we can even start like front load our patient activation out at registration, this can be helpful to our clinic visit and to the time intensity that we have within our clinical visit. So one of my suggestions is to consider, if it works within your system, to think about moving agenda setting out to registration or to whoever's rooming the patient. So in preparing for the visit, a couple simple questions, but more importantly, on the back of this sheet might be a question about vaccinations. And this is another way of discerning sort of disposition before a patient comes into the exam room or you enter the exam room. So a couple of questions we might ask would be scaling questions as part of the clinic's effort to improve patient care. How important is it for you to be vaccinated against COVID-19? 0, not at all, 10, extremely. How confident are you in being able to arrange to obtain a vaccine? Again, a scaling question. I'm going to provide a couple of slides about what to do with these scaling questions. I'm not going to go over those right now, but there is a knack and a definite directional way of using scaling questions that help patients argue for change, their own change, and do that work on behalf of themselves. So this material will be included. And then I wanted just to give a little bit of time and attention to a tool that we thought might be helpful. And we're interested in getting some feedback on this and testing this within the clinical setting. So this is the EASE. And the first part of EASE is to elicit the main concern. And this is, we begin the appointment by setting that agenda, and we approach that COVID-19 vaccine conversation with empathy. We might use open questions. We might use a scaling question, as we did on the patient activation form. We might use other types of open questions. With eliciting main concerns, we're going to resist the writing reflex, avoid telling a person what to do, and instead use empowering language. So this first part is eliciting main concerns. This is just really curiosity. You know, what are your main concerns regarding the COVID-19 vaccine? If they haven't gotten it already, or if they're saying they don't really want it, what are your main concerns? Good open question. We want to acknowledge the main concern. We do that by just expressing with empathy how that person might be feeling. It could be you have a lot of questions, you're not quite sure who to trust with information, you're worried about infertility, you know, all of those kinds of things. It's just providing that back with your genuine, authentic reflection. And then actively listening to your patient, seeking to understand where they're coming from, and reflect what you're hearing. Then share your commitment. So this might be, you want to honor that patient's autonomy, and at the same time, you want to share your commitment. This is your role as a person's healthcare provider. And you might say something like, you know, I am really committed to keeping up to date on any vaccines I recommend, including the COVID-19 vaccine. You may provide some advice to them. This is part of sharing your commitment. If you're providing advice, in order to guard against the writing reflex, we recommend that you ask permission. Would it be all right with you if I make a recommendation? Patient, depending on your engagement with them, I've never had a patient tell me no when I've asked for permission. I'm very engaged. It could happen though. If they say no, it's then the time to leave it and say, okay, that's fine. I would like to talk with you about this at another time. We'll leave it for now. If the person says yes, then you can say, you know, whatever kind of information they were seeking, based on my information, the current information, I do recommend that all my patients get vaccinated. What do you make of that recommendation? And then educate and endorse the research. So this is the last E in EASE. And again, this is with permission. But when your patient is asking direct questions, that is implicit permission. So if a person says, I'm really worried about fertility, what about for infertility? Then that's implicit permission that you can go ahead and give information without asking for permission. This is all about honoring that person's autonomy. And then provide clear and concise information based on that person's level of understanding. So make sure that it's relatable and understandable. And then you might ask the person, what do you make of that information I shared? I also like to chunk out information. I recommend 1 to 3 points and not a lot more than that because it gets lost. So